Welcome everybody, welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast, and today we have made it to rule number 100. I'm only going to discuss one rule this morning, and it's a very important rule that actually came into play several times already in my clinical practice. And rule number 100 says, not all tachypneas are respiratory issues, and not all vomiting means a GI problem. So this rule is really all about premature closure, and if any of you don't know what that means, just from a simple Google search, premature closure is defined as powerful bias accounting for a high proportion of misdiagnosis. It is the tendency to apply premature closure to the decision-making process, accepting a diagnosis before it has been fully verified. Outside of medicine, premature closure is just another well-known bias associated with diagnostic errors. This is the tendency to cease inquiry once a possible solution for a problem is found. As the name implies, premature closure leads to an incomplete investigation of the problem and perhaps to incorrect conclusions. And if you are in the business of medicine, specifically in the business of emergency medicine or pediatric emergency medicine, and it has not happened to you yet, it very likely will. Oftentimes, we see a patient, and before we do a workup and really think hard of the case, we make a diagnosis in our mind, and it's very hard to deviate from that, and sometimes that leads to diagnosing errors and even some bad outcomes. So this rule is all about premature closure. Specifically, I named that rule based on several experiences I have experienced myself or seen with other providers in the past, and this is why I refer to tachypnea and GI problems specifically. So as usual, no better way to demonstrate the rule than with an example. It's 2016, I just finished fellowship not too long ago, and my very first patient signs in, I'm the attending for the very first time, and the chief complaint is vomiting. Well, as you know, vomiting is almost always a GI problem, namely gastroenteritis, and in my head, I already have a fairly narrow differential diagnosis. When I went into the room and spoke to mom, I learned that the child has been vomiting every day for a week. However, it seemed very odd to me that despite him having the symptoms every day and vomiting several times, he did not have any other GI symptoms. In other words, he did not have diarrhea, he did not complain of abdominal pain, he had no viral-like symptoms of fever, congestion that will indicate a viral illness, and I remember thinking about it and it seemed very odd. I proceeded to do the physical exam and his abdomen was completely soft, he was able to jump, had no peritoneal signs whatsoever, and thinking hard of the case, I started thinking that maybe this is actually not a GI problem. Unfortunately, as we all know, increased intracranial pressure can also cause vomiting. I proceeded to do a Babinski reflex, which unfortunately was positive, did a head CT, and unfortunately diagnosed the child with a head tumor. Now, I can't exactly indicate what made me think about increased intracranial pressure, perhaps just medical knowledge, but subconsciously I think the fact that the child was vomiting for so many days but lacked so many other GI symptoms made me think about that the most. And it was a very, very good lesson. So remember, not all vomiting is a GI issue. Another example, and it's the second part of the rule, not all tachypneas means a respiratory problem, was a child that I saw several weeks ago with a resident. If I recall correctly, he was a toddler, about 3 or 4 years old, and the chief complaint was fast breathing. My senior resident actually went into that room, and he learned that mom thought the child has been breathing very fast. She actually took him to the urgent care 2 days prior. He was checked for COVID, and that's it, and was discharged with a diagnosis of viral illness. When the nurse obtained the vital signs and my resident did the physical exam, there was significant tachypnea of about 50 breaths per minute. Now, I think it's very important to understand, 50 breaths per minute for a 4-year-old is a very significant tachypnea. And in my mind, if you're tachypneic to such a degree, you should really have some respiratory symptoms, either by history, cough, runny nose, congestion, or by physical exam, wheezing, crackles on exam, something. This child was breathing so fast but was lacking any other respiratory findings on exam or any other respiratory complaints by history. I remember my resident struggled for a little bit. I, on the other hand, was lucky to have seen such a case before, and I immediately thought about DKA. I discussed the case with my resident, and eventually we came to the conclusion that perhaps checking the glucose will be of value. Since again, the child had no wheezing, no crackles, no tachypnea, probably a chest x-ray will not be very helpful. We obtained the glucose, and lo and behold, it was over 600. The child was in DKA and had Kussmaul breathing. So going back to rule number 100, not all tachypnias are respiratory issues. Again, I think it's important to remember that if you're so tachypnic, you really should have some respiratory findings, either by history or by physical exam, or both. A child that is so tachypnic with no respiratory issues whatsoever, you gotta think about Kussmaul breathing and DKA. Another good example to think about premature closure and thinking outside the box is the child who presents with eye swelling. Again, this is a common physical finding that we see fairly often. It's almost always allergic conjunctivitis or viral conjunctivitis causing the eye to swell. This is almost always very common in the morning since the swelling is basically fluid and edema that accumulates when the patient is supine all night, something that I see very often. Parents complain that the eye is swollen. Sometimes they say that it was wide shut from some discharge and whatnot. So this child came in with significant swelling to the eyes for several days. As with the other two cases, again, I think it's important to remember that when you see such physical exam finding, you really got to think hard before you decide what your diagnosis is. So a child who has significant bilateral eyelid swelling from conjunctivitis, be it allergic or infectious, really should have some other physical findings by history or exam, namely red eyes, since there is inflammation involved, or maybe discharge, or maybe ask the mom if the child has been itchy, etc. A child that has none of the above, you really have to entertain the possibility of minimal change disease, and that's exactly what this patient had. So again, if the child has such significant swelling for so many days, ask the mom and check on your physical exam if there are any other signs of conjunctivitis, in other words, inflammation of the eye, discharge, pruritus, etc. So again, remember, try to avoid premature closure and look for those signs and symptoms of physical exam that will really explain such swelling in the eye and the physical exam you have in front of you. Lastly, I want to say that premature closure, again, is likely going to happen to you if you're a physician, especially if you're in the business of pediatric emergency medicine or emergency medicine in general. And in my opinion, the best way to avoid it is to obey rule number 47, which I discussed in episode 11. The way to become an expert in your field is to see a lot of patients. I was able to think about DKA in the child with tachypnea because I've seen it before. I was able to think about minimal change disease in the child with the swelling of the eye because I've seen it before. So remember, the way to become an expert in your field is to see a lot of patients. Try to keep an open mind, think about premature closure, and always widen your differential. If the physical exam and the history together don't make sense, open your mind and think of what else can this be, even if it's a rare or uncommon diagnosis. So obviously there are probably many other examples for premature closure, which I would love to hear from you guys if you experienced any of them, and if you have any rule to avoid them in the future. Those are just my experiences. So please check out PEM Rules and submit any feedback or any examples you may have to rule number 100. Remember, premature closure is an issue, try to avoid it, and probably the best way to do it is to see a lot of patients. And that is it for today, guys. Thank you very much for listening. This outro is one of my favorite songs to play on the electric guitar with the distortion. This is by the Pixies called Where Is My Mind?